The slides I'm going to present and the way I'm going to present them are going to be, I hope, relevant to a lot more folks out there who aren't experts and who may not have had firsthand experience with hereditary cancer families or with genetic testing. But I'm hoping by the end we will have a good discussion, those of you who still have some energy and active brain cells, to discuss really the question of, is it ready for prime time in any setting? So in your clinics where you have, you're giving pertuzumab and you've got PET CT and everything else, you've got molecular pathology clearly. Okay, fine. So basically you have the same setting as I have in New York. But what of the rest of the country, right? And so that's what I want us to be thinking on together. I have no disclosures except the one you already heard yesterday. Being from a system that has universal health coverage, I'm used to thinking in terms of the rational use of resources and the rationale for doing what we do, because often I don't have a choice, right? It's the payer is the government, right? And they're going to be deciding using health technology assessment and other mechanisms of what is reasonable for the entire population. For example, the population of Ontario. In New York, where I work now, the insurers have that kind of leverage, and that I don't mind because they are following guidelines, in this case NCCN guidelines for genetic testing. So the 1-minute primer I'm going to give on clinical cancer genetics is for anyone watching this talk who aren't familiar with it. And for those of you otherwise, it's fine, you can take a nap. New frontiers in genetic testing, multigene panels is really where we're going now, and I think the future is already here. Exome sequencing, I'm only going to mention once to say, doesn't have a lot of value if you're already doing a large panel, but we can discuss that after if you want. Considerations for health equity and health policy is really what the focus is now. So the genetic architecture of cancer risk can be shown this way. On the left-hand side, you've got the allele frequency, meaning the frequency of genes when mutated, when you have a pathogenic variant, each of which cause a very, very small risk. That would be like the single nucleotide polymorphisms, the SNPs. And don't have a lot of time to talk about polygenic risk scores, but if you want, we can talk about it offline. Rarer and rarer variants include the high penetrance genes such as BRCA1 and 2, which we've already heard a lot about, and also PALB2. How many people here have not heard of the gene PALB2? So everyone in the room is an expert. Okay. I don't think I'm going to go through too much of this, just to say we've heard about mismatch repair genes earlier with respect to Lynch syndrome. Homologous recombination this is all about all the different ways in which DNA can be damaged in a natural setting in any human being, and the mechanisms to repair these, which do influence a few things, including the presentation in hereditary cancer and also potential targets for therapy, which I'm also not going to get into. We've heard a lot about that today, especially today in the breast and GI and now GYN gynecologic oncology sessions. So if you look at this pie and you see the blue and you see the gray, I hope it shows gray, and you see the orange, and they break down into what we call hereditary cancer, really meaning a highly penetrant gene that, when mutated, is going to cause a high risk. Then we have familial clustering. So there's all those families, including some of you have discussed with me this last 24, 48 hours, where the genetic testing's negative, but the family history is still there, and the question becomes, is this hereditary but it belongs to a gene that we don't know about yet? Or is there something else that seems to be running in the family raising the risk? For example, a family of smokers might all be at increased risk of lung cancer. So I think it's pretty obvious to this room that hereditary falls into the gray, familial clustering falls into the orange, something like 20%, hereditary being 5 to 10%, depending on the population, but sporadic meaning most cases of cancer are not caused by a hereditary factor. So when to consider cancer genetic testing, I'm going to breeze by this because I think we're moving past this in many settings, and we have to have that discussion now. This is going to be very relevant here in a setting where a lot of people don't have a family history, meaning they don't know of their family history of cancer, or people who are aware are not sharing the information for cultural factors, for factors regarding stigma, etc. But traditionally, we looked at people with early onset cancer, less than 50, less than 40. When you see similar or related cancers in multiple generations, and I give this talk to primary care providers all over the world who don't know anything about hereditary cancer, I think it's still good to go back to first principles. Individuals who have more than one cancer, I sometimes see in my clinic people with 5 different cancers. We often don't still find what the genetic cause is, but multiple cancers in an individual, bilateral cancer, so bilateral breast cancer by itself happens by chance, so to speak, or whatever the other factors are that raise the risk that don't include a strong hereditary factor. But if you see a woman with bilateral breast cancer before the age of 50 or 40, that's highly suspicious for something going on. Then there's certain ethnic groups. I keep this on the slide because in my population in New York and in the US, Ashkenazi Jewish people are very frequent in the population, and so we have a high proportion of BRCA founder mutations in the community that I serve. Individuals with a known gene, so obviously anybody coming to the clinic who says, we have a BRCA gene in the family, make sure you look at it, make sure you see the report yourself. There's a lot of miscommunication and misunderstanding, particularly with variants of uncertain significance, or VUSs. Okay, so BRCA1 family, I think I'll just show this for like 30 seconds. The red are people with cancer. You can see the woman here. I know I don't have a pointer, but I'm struggling to use the pointer here. Here's the proband, the index case, 35-year-old unaffected woman whose sister had breast cancer at 40, whose father is 72 without cancer, but the proband lost a paternal aunt to ovarian cancer at 68. And then there's a paternal first cousin with breast cancer at 37. This is sort of a classic family. It would be even more classic if the father had either male breast cancer, or died of aggressive prostate cancer that he might have been diagnosed with early. The important thing to note here is that in the general population, what population? So we need ethnic diversity in our data sets to understand this better. But in the general population, which was predominantly Caucasian in the initial years of acquiring families for research, we think it's about 1 in 500 to 1 in 700 people who carry this mutation. If you're Ashkenazi Jewish, by the way, it's more like 1 in 40. It's that frequent. So this is from NCCN 2019, just to show you the risks. The only comment I'll make here for this audience, because you're all very familiar with BRCA, is that if you look to the column that says breast cancer for women, BRCA1 and 2, you'll see that it says up to 65% for BRCA1 and up to 55% for BRCA2. If you asked me 5 years ago, I would have said up to 80% by up to 80. Okay, so a lot of people still think it's as high as that. You might ask, well, what's the difference? It's still high enough to recommend risk-reducing mastectomy. However, if you're that individual, the difference between a 50% risk and an 80% risk is very significant. And the point I want to make here is, this is still a moving target. We are still learning about the penetrance and even the variable expression of and modification of risk in families with BRCA1 2. I belong to a research consortium led by Dr. Stephen Nayrod at the University of Toronto, who I worked with since I was a cancer genetic counselor in the early 1990s. He has a data set of 15,000, now 16,000 BRCA carriers from about 10,000 families in 10 countries, 50 centers. We're now starting to try to recruit more people from different countries. We've got quite a few individuals from Hong Kong and China, but not much from South Asia yet. All this to say, in ascertaining these families, we were inherently biased when looking for BRCA1 and 2 in the early 90s, because what? Who are the families who are going to participate in research? They're going to be the ones who have lots of people, lots of women with lots of cancer. They're the ones who you're going to say, you know what, Ms. X, we would love it if you could participate in this research study. Could you talk to your sisters, your mom, your aunties, etc., and see if maybe we could get a blood sample? And that's the research that led to the discovery of these genes. And so we've biased our own data set with highly, penetrant mutations, or at least families where, for whatever other reason, the non-genetic factors unmasked this tendency to develop breast cancer, and we see a lot of breast cancer. Does that make sense? Likewise with ovarian cancer. Look down to the column there, and you'll see under BRCA2, up to 18%. That's still very high because we don't really have as good screening as we'd like to have for ovarian cancer, but that's a whole lot different than it was about 10 years ago. Okay, so the decision making is important, and in the case of BRCA2, the timing at which we recommend preventive bilateral salpingo-oophorectomy, BSO, has also been changed. It's later. So we know that in BRCA2 families, the ovarian and fallopian tube cancer happens much older, and that's good. So those women can be spared at least a few more years, 5 more years, before considering having this unfortunate surgical menopause, which, as we all acknowledge today, is not a walk in the park. It's actually a serious issue that has a lot of impact on quality of life and other health issues. So here in the NCCN 2019 guidelines, you'll also see a couple of things changed. I'm just going to show you here about removal of, this is just a comment on the age 40 to 45 is now when we recommend BSO for BRCA2 patients. Lynch syndrome, I don't think I'll mention much because we covered it really nicely this morning. There was a whole discussion about it. But just to remind us that for those of you who don't usually deal with hereditary cancer, who might not have access to IHC or microsatellite testing and everything else we've talked about here in this room, in a common sense way, when you hear about a family, for anybody who's looking at these slides or listening to this talk, and you hear that there's colon cancer and also uterine cancer in the family, that should raise a red flag. Now, you would be surprised to know that even where I practice in New York, there are a lot of doctors who don't recognize Lynch syndrome. They know about hereditary colon cancer, but they don't know about the full spectrum of cancers in Lynch syndrome. So that's the only statement I think that's relevant at this point today. This was a slide that some others put together based on Walsh, our genetic counseling team at NYU put it together to show the trajectory from, you can't see that, but from 1994, 5, 6, et cetera, with the discovery of BRCA1 and 2 to what happened when Myriad had the patent, right? And they had really the market on doing the testing. The testing for those 2 genes alone was $4,000 US, really out of reach for many people in the United States. In Canada, we were doing our own testing in our own very high quality labs and hoping not to get sued until the patent was struck down just a few years ago. And that opened the door for a whole bunch of things. It opened the door for competition between laboratories. And as a result, the prices have come down considerably. And at the same time, technology advanced with high throughput sequencing that we're able now, as you know, all of you in this room, that we're able to do multigene panels. And the multi-gene panel can cost just a couple of $100s now US, and that's obviously it can be much cheaper in other places. Perhaps it's more expensive here, and we can ask about that. What makes sense? The testing also can be simplified. The testing itself can be done by sending in a spit kit, right? You don't even have to see somebody. But the counseling and the interpretation of results is absolutely essential to proper, high-quality clinical genetic services. And this brings me really to the point of the talk. So ASCO came out with a statement in 2015 about genetic and genomic testing for cancer susceptibility. There are other such important statements like the American College of Medical Genetics, but for this audience I think it's relevant just to remind us that some of these, all of the features of the statement are still relevant today. It's only a few years old. I'll show you another slide in a minute on this. This is to remind me to say that, remember I showed you the 2019 NCCN for genetic testing? Boom, it's already outdated. And I just woke some of you up, that's great. So outdated because, well, they keep changing the guidelines because there's more and more evidence for the frequency of other people to have BRCA and other genes is coming to light. So for example, it's been a number of years now, and we have an expert here who can tell us in GYN oncology that all women with epithelial ovarian cancer are now offered, or should be offered, testing for BRCA1 and 2 at least. Here in New York, we give them the whole panel, an ovarian cancer panel. Okay, so we've already known that in one particular type of cancer, it's important to be able to offer people the test because 15 to 20%, especially for papillary serous ovarian cancer, 15 to 20% non-Ashkenazi Jews, just average Caucasian, but also we see this in African American women, and we're looking into other populations, will carry a pathogenic mutation or pathogenic variant in BRCA1 or 2. But now, anyone with advanced prostate cancer, that's a big population. Anyone with advanced prostate cancer and anyone with pancreatic cancer, regardless of ethnicity, age of diagnosis, or family history, now are recommended to undergo genetic testing according to NCCN. So, oh my goodness, we have a big program in New York. I've been lucky enough to hire a lot of counselors. I think there's 15 genetic counselors in the country of India. In the city of New York, I have 7. And that's one of 3 or more cancer centers that have genetics programs. And we still don't have enough. So what does that mean for offering testing in the clinic? This is just to show you a ridiculous slide with a whole bunch of genes that we now test for. One of our labs has an 83 gene panel, and frequently the genetic counselors go through a discussion based on family history that looks like, yeah, there's breast, but there's also colon, but there's also maybe somebody had a paraganglioma or something. You end up with a big gene panel, and then, boy, does the counseling get complicated. Because when you get beyond BRCA1 and 2 and the Lynch genes, which we know a lot about the variants, there's fewer and fewer variants of uncertain significance, at least in a predominantly Caucasian population that has been studied well. The same cannot be said for all these other genes. So we get lots of variants. I get results every day that have variants in 3 genes. Okay, we don't even know what these genes do. They're not even necessarily actionable. Why are they on the panel? That's rhetorical. So this is to show you the latest NCCN, well, that was from February, I think it's already been updated, that included any individual with a pathogenic variant in a tumor, okay, so that, tumor testing, which we've already talked about today. We should think about what's happening in the germline. So there's some guidance there. With BRCA1 and 2, it's pretty clear that if the tumor, regardless of what tumor we're talking about, shows a pathogenic variant in BRCA1 or 2, it has a high enough likelihood of reflecting the germline that that person needs to be counseled. So what happens in the clinic? Okay, I get a 72-year-old man with metastatic lung cancer, poor guy. Bad enough he's at the point where he needs this testing to help decide on treatment. And now we have to tell him, by the way, you carry this gene that puts the women in your family and the men at high risk, the women in particular at high risk of cancer. Well, was he counseled about that when he agreed to have the tumor testing? These are things we have to think about. We have to think carefully and put into place ethical and regulatory and sometimes even legal protections for patients and families before we just willy-nilly start doing all these tests. So NCCN multigene testing, this was from a year before, is ideally ordered in the context of professional genetic expertise for pre- and post-test counseling. Why? Why do we do it? For risk prediction, risk reduction for patients and their family members, and for tailored treatment options. I can't remember why treatment was bolded, because I'm not going to discuss that in any more detail. But note the part about the family members. That means, in order for this to be an effective system to reduce mortality from cancer, at least in the higher risk families, we need to show that if I give you a gene test result, that you are going to then inform your family members, and that your family members are going to be interested in coming, and that they are going to take action. We sometimes call that cascade testing. For the system to actually be effective and cost-effective at population level, you got to get cascade testing right. And even in New York and in Toronto, where we have lots of genetic information out in the literature, lots of media attention, and a relatively well-informed population as well as the providers, we're not doing a good job at all of cascade testing. We need to innovate solutions to help overcome that obstacle of putting the onus on the individual to tell their family members and then to do all the legwork there. So the implications for patients, providers, and policymakers, as well as health systems, can be framed the way they did in that ASCO policy, the statement, and then there was an editorial in JCO. First, they talked about the 3 technical considerations. One is there has to be analytical validity, okay, which sounds like, yeah, but there's actually a lot of discordance between the labs. Now, these are appropriately certified and New York State approved. In my state, there's all kinds of requirements So these are very high quality commercial laboratories that have gone through all the necessary steps. And we often see a difference of opinion. 2 of the labs says this is a VUS. 1 of the labs say it's pathogenic. And so in the clinic and in my weekly case conference, I have a multidisciplinary case conference for genetics. The counselors, myself, I happen to be an oncologist who's specialized in genetics, but we have a real life clinical geneticist as well. We're very lucky. Many programs don't have that. And together, we look at the variant, we look at the change in the gene. Sometimes we even put it into, well, we always put it into the publicly available database called ClinVar. But even ClinVar sometimes doesn't tell us the whole story. And then we look to the geneticist in the room who happens to really have such a sharp mind and is able to sort of help us adjudicate. We're not going to reclassify the variant in the clinic, but we certainly can look at what makes the most sense functionally. What do we understand? We'll even do a separate literature search. We'll call the laboratories and ask if anyone is at the point of reclassifying. This is a lot of work, and this happens quite often. And this has real implications for the people that we're trying to help. Clinical validity means there has to be a reasonably reliable evidence of the strength of the association between that pathogenic variant and the disease. Okay, remember I showed you that big list at 83 genes? Even if you look at the 25 or now 28 genes that one of the companies, the one that had the patent, Myriad, currently has on their basic MyRisk panel, we don't have a lot of good evidence for some of the recommendations, and often there are no recommendations. I'll show you a NCCN chart that actually you can see which genes are commonly being tested for, and then there's just a question mark. So I always ask, why are we doing it if we don't know what it means? Clinical utility means proven evidence for the information that leads to prevention, and survival benefit or mortality reduction, not always clear. Now, clinical utility demands that patients have access to care for the enhanced interventions, whether it's screening with MRI for BRCA1 and 2 versus, of course, preventive surgery or chemoprevention, as we heard about earlier. Patients and families have to have some type of coverage, not just for payment, but also the insurability. They should be protected from discrimination. In the US, there's the GINA, the Genetic Information Non-Discrimination Act. In most countries, there's nothing. In Canada, there wasn't until recently. So, this brings us to equity. I always like these slides. Equity versus equality, right? I think you've all seen this. But on the left, you can see that there are 3 individuals of differing heights, all trying to see the, can I pretend it's cricket, not baseball? They're all trying to see the cricket match. And you can see that they each have an equal height box. So, they're given equal access, but it's not equitable because at least one person can't really use that to their benefit. And so I encourage us to think about everything we're doing, that we're discussing in this Choosing Wisely event and the event also in Kolkata, to be always thinking about the equity lens, the framing of what we're able to offer for everyone. Now, we'll never be 100% equitable in everything, right? I mean, that's the ideal. That's utopian. And even in my country, in Canada, there are large segments of the population who do not have equal access to cancer care, even though it's funded and we have universal health coverage, etc. But the reality is that women and men who are living in Northern Ontario have a hard time accessing the same care that we can in downtown Toronto. So let's not fool ourselves. This is all about developing low and middle income countries versus we are all in this together, and equity should be about everyone. This is just to mention that there is a lot of emerging data now in other populations I alluded to earlier. Ava Kwong has led this with Dr. Su. Ava is in Hong Kong, and Dr. Su, who is in Malaysia. And we published this together as a comprehensive spectrum of BRCA1 and 2 in about 10 Asian countries. And then this one included our colleague here from Tata Memorial, Dr. Sarin, regarding the status of hereditary cancer counseling, right? And we all know that counseling is a big issue, and it's there's a great lack of it throughout the world. Trained genetic counselors, even if you offload the pre-test counseling to a chat bot like we're doing now at NYU with a grant I have, or do online-based, WebEx-based counseling for people in group settings where it's confidential, they don't know who each other is, but it streamlines the process of information, informed consent, etc. The interpretation of results and the post-test counseling still requires people who have training. So what about India? So this is a recent paper I found in Breast Cancer Research and Treatment, and some of you in the room may be on this paper, but I was glad to see that there is a lot happening here regarding our understanding of frequency of mutations in actionable genes in this population. This was a study of 1,000 patients in India with breast or ovarian cancer using a multigene panel. As I recall, it wasn't a huge panel, but the bottom line, the reason I'm showing it, and obviously not in huge detail, is just to say that this is happening. It was 14 genes. That's right. It was a 14 gene panel, and they detected mutations in 30% of the cases, and 56 of those mutations were novel. Okay, so let's break that down just for a second. 30% of the cases, so remember, we're talking about families with cancer, right? The people likely to participate in research are those with lots of cancer in the family and lots of family members available for research. So in all of these studies, I would caution you to think wisely as well when you're looking at the large studies being published in the major cancer research journals now, hundreds of thousands of patients. There was two major labs in the US, each published very good papers recently that then led to recommendations like the American Society of Breast Surgeons made just a few months back, saying all women with breast cancer, regardless of age, family history, ethnicity, should have testing. Okay, well, what are our resources? Where did that data come from? It came from research based on populations referred for testing. Who are those people? They're people with family history. So we have to be a little bit cautious about this, or more than a little bit. So here as well, 30% of cases. Does that mean that hereditary breast cancer is way more common in India? Probably not. Any other study so far that's been looked at, as far as I know, and I'm in a room full of people who might know a lot more than me about this, I believe it's still about 5 to 10%. There are some founder mutations in some of the populations studied here and throughout South Asia, and this is a great opportunity to engage in research to learn more about that. But the bottom line here was the authors pointed out that while this proves there is a role for genetic testing among cancer patients here, because why wouldn't there be anyway, socioeconomic inequality limiting access to treatment is a major factor, right, towards the increasing cancer burden. So the incorporation of a cost-effective, that was a word they threw in the conclusion, and a comprehensive multigene panel will be helpful in ensuring widespread implementation, uptake, and benefit to the patients. So do we have cost-effectiveness data here? I don't think so. There's actually surprisingly little cost-effectiveness data on BRCA1 and 2 anywhere, but there's been 2 good papers in the last couple of years, one which literally came out like October 3rd. And I'm writing this up now for Nature Reviews Clinical Oncology with some colleagues at IARC and also in Porto Alegre, Brazil, to look at the body of literature that can help us inform what we're doing next. It's just a big review. So this cost-effectiveness analysis of multigene testing was done in the UK at the London School of Hygiene and Tropical Medicine. And the question they asked is, in unselected genetic testing of all women with breast cancer, is it cost-effective compared with testing based on clinical criteria? Going back a bunch of slides to where I showed you, indications for testing include family history, early onset, ethnicity, multiple cancers, pattern of cancer. The movement in North America and Europe is increasingly towards population-based screening. And in countries and in populations where family history information is really lacking, that actually might be the best strategy over time if you can ensure equity and all of the other things I'm mentioning. But I would encourage us to think, if you're going to do it, how to make it the most cost-effective and useful for the population. So this was an interesting study that used a lot of modeling, and we don't have a lot of time to go into this. I know it's a long day. I'm just going to end with Oh, I just actually lost the little flash for this. But anyway, the findings supported that it was that it was cost effective in terms of the UK system, and in some health systems, because they looked at different types of health system coverage in the US, was also considered to be cost effective, in terms of quality adjusted life years. But that's the US and that's the UK. Okay? And it's still not affordable. So what is it here? We put this together also, myself and Dr. Paul Brennan, who's the section head for genetics at IARC. We wrote this editorial in JCO last year. Can we make an impact on population health with multigene panels? And the reason we wrote it was it was prompted by a study in Nigeria, which was a very good study with Dr. Mary Claire King and Dr. Fumi Olapade at the University of Chicago, who has done seminal work in Nigerian patients, especially with triple-negative breast cancer, et cetera, et cetera. But the conclusions they came up with were that it was time to have population-based testing for all women with breast cancer in Nigeria. And so, had to think about that. What are the things that we need to make sure that that's relevant in Nigeria? And how would that relate to other countries where the expenditures per health are much greater, like they are in India, although they still have a long way to go, if I might say so, and where there is a lot of opportunity for risk reduction strategies in the urban settings, in the places that you all represent, in these high-quality cancer centers. But what about the rest of the country? Anyway, so we came up with a set of suggested considerations, technical, regulatory, and health systems considerations. And I'm going to end with this. These are just questions that are wide open for us to discuss, and it's a long day, but maybe we can discuss offline, or you can do so amongst yourselves. Number one, what is understood about the acceptability of genetic testing for hereditary cancer in a community? And I say a community because India is a huge country with many communities and many ethnicities and many social structures. Like any country, what's good in one setting may not be appropriate in another. And so we should really ask, our community members to be very much involved in these decisions. Does testing include comprehensive education, post-test counseling by trained providers? And I remind myself here to say many ordering providers, because anybody can order a genetic test in the US. If the patient's willing to pay out of pocket, or if it's covered or whatever, they get it wrong. And I've seen too many women in my own clinic, referred from elsewhere, who had a bilateral mastectomy or TAH-BSO with a variant of uncertain significance and a BRCA gene. So who will interpret the variants of uncertain significance? This can be a lot more complicated than people think. The workforce and technical capacities for risk reduction interventions. We've talked a lot earlier, yesterday I spoke about population-based average risk screening and how we don't recommend mammography for average risk women in most settings unless a lot of system elements are in place. But for high risk, well, there may be value in trying to strategize who the high risk women are in the population, and maybe start there with screening or enhanced screening. That's something worth considering. Surgical decision making is challenging in any setting, and for any one individual undergoing discussion regarding prophylactic surgery. Is surgery acceptable? Is it acceptable to have a mastectomy if you haven't had breast cancer? And this has been studied pretty well in a lot of different populations in different countries, and it's highly variable. So we shouldn't make assumptions on the uptake being X percent, right? And if it's not going to be X percent and there's no access to MRI, then why are we doing the test? Okay. Well, I mean, in case of BRCA, we're also doing the test for ovarian cancer risk reduction. But even there, convincing a woman to have surgical menopause at 38 or 42, well, that's important, especially if she's childbearing for many more years, etc., at a young age. So what is the role of clinical genetics in global cancer control, and how does that relate to India? Are we ready for prime time here? And what would be the core elements needed to ensure that this service could be part of provision of high quality comprehensive cancer care that's cost effective and equitable? Okay, and I'll end there. Thank you.